You go here,
Here,
that one.
that one. Oh, thank you so much.
Yeah.
You just saved the day. Go.
Great. Thanks, everyone. It's a real pleasure and honor to be over here. And we have this recurring joke at Google that we'll probably get to AGI before we solve audio video for presentations, and there's always like a hiccup everywhere. But yeah, I did change the title of my talk in the last minute because I wanted to be a little bit more provocative and ambitious about what we're trying to do. And so to maybe provide more context, so yeah, I think in previous talks I've mentioned this, but like I kind of like grew up in India and in many parts of the country where I grew up, for people getting access to medical expertise and going to see a doctor was often a challenge. And it often meant like, walking 30, 40 miles in extreme heat or, giving up on a day's wages or going without food. And so, I mean, I kind of knew people who had not seen a doctor in their entire lifetimes, and it felt like one of those root node problems that if we as a society, if we as humanity can do better at, then we can unlock a lot of potential in human species, in humans, because again, like access to medical expertise should not be a bottleneck for people. And so it's been one of the like motivations for me and also like many other people who have been with me in this journey at Google, to try and see what we can do about this problem. So I've been like very, very fortunate to work at Google, and I think roughly we've been doing at this for over a decade, where we've been trying to like train AI models. And let's see, what's this? We've been trying to like train AI models, and we like to call our projects like trying to send them to medical school. And no, this one was not created by Gemini, but by our dear friends at OpenAI, DALI. So yeah, so what we've been essentially trying to do, and this is a recurring theme for over like I think 10 years now, is like we've been trying to like get these AI models, train them on like high quality medical data, do like very rigorous verification and validation, and try to align them to the values and the practice of medicine. And I would roughly say that there've been like 2 years to this kind of work. And so one year roughly started in around like 2016, when many of my teammates did like the seminal work on like diabetic retinopathy, where they showed that modern deep learning models, computer vision models, can do very good at like specialized computer vision tasks. And that I think roughly went up to like 2020, 2021, bunch of different Nature papers, bunch of different specialized models that when evaluated in narrow settings were doing like very, very well and often comparable to experts. But I think the real shift happened roughly when large language models came up online. And so this was, I guess, a dinner conversation that I was having with my teammate, Dr. Alan Karthikeyaselingam, back in 2022. And it was right after we had gotten access to one of our first big large language models. And so there was like the Palm-based models. And we went out for those as it was COVID. But like my mind was blown simply because for the first time we were seeing evidence of like almost like few shot learning, zero shot learning with models that can understand language natively, can understand medicine natively. And so that really like, motivated us to ask this question. I mean, there's going to be a game changer for medicine, because this has been the problems that we've been trying to like solve for like 4 or 5 years with these specialist models, and we've been running into challenges continuously. And now we finally have like a system with language as the grounding, as the scaffold, that maybe allows us to overcome a lot of these challenges and really uh, make like AI models really better suited for applications in medicine and healthcare. And so we started on this journey, and I think we're kind of pretty early as that time. Like what we were first trying to do was to see like how well do these models encode medical knowledge. And so we took those MedQA and other like question answering data sets. We tried to see how well these models performed, and roughly before these big LLMs, the performance on these benchmarks for over 10 years was fairly, like I would say, not really progressing, fairly static, like maybe close to like random performance. And then suddenly boom, after language models, not just like from Google, but also from like, OpenAI and a bunch of others, the performance on these benchmarks like really went up and to the right over like a short span of like few months. And so with MedPalm, I think this was one of the first systems that had like passing level scores on these USMLE style questions. And then with MedPalm 2, we were able to get to more like expert level performance on these self-contained benchmarks, right? But I think the more interesting thing was actually the graph on the right. So when we moved beyond like just these medical licensing style exam questions or these knowledge tests and moved more towards questions that were more reflective of like real world use cases. So that's when we saw like some very interesting results. And so on the right is like a graph of like questions that were derived from like queries that people were making on Google search for when they were looking up like medical related information. And then we looked at like what the answers the LLMs were producing versus what the answers were like physicians were coming up with. And then when we did like a comparison with like a third panel of like clinicians, we saw that like actually clinicians were preferring the LLM generated answers. And they weren't only like preferring them for things like knowledge comprehension and recall and things like that, but also around axes like safety and bias. And so that told us that okay, that these models may actually be more well-rounded and comprehensive than we had thought before. And maybe we are closer to making them having like real value in real world applications. So that gave us a lot of confidence. And obviously the research that we did, it's received quite a bit of attention. But again, as all of you know, and the reason why we are over here is like, we know that medicine is inherently a multimodal endeavor. And so we moved on to like try and see, okay, like we have language models, can we add like more multimodal capabilities to it? And I would say like MedPalm multimodal was one of the first efforts that we did towards that. I think this was maybe now, it's now 2 years old now. And I know that Pranav and a bunch of others over here have been like pioneering this concept of like generalist models. And I think this was one of the first examples of like a truly generalist system, in the sense that like the same set of model parameters could do multiple different tasks to a high degree of accuracy, I would say. And so not only was this model capable of like language-based interactions, but it could also interpret different kinds of medical images, genomic data, like grounded responses in the context of an health record, and things like that. And so it was kind of useful. And so like you could, for example, like give it like a radiology image, ask it to come up with like a report of that, and it would do a pretty good job. And I think it like one of the key results was it was among the first systems to approach like radiologist level performance in control settings on this report generation task. But there were limitations. And so if you roughly think about like how we could add like multimodal capabilities into these big language models, I would say that there are maybe 3 different approaches at a high level. So one is you could keep the multimodality aspect of the knowledge or the capability completely outside the language model and invoke them as like tools or specialist agents. That is good in the sense that you can keep the development separate, you can keep everything separate. It maybe allows you to like move faster. But I think there are like a lot of things that we leave on the table with that approach, but that's still like valid. The second approach is like what we essentially did with like a MedPalm multimodal work, which is like this grafting approach where the parameters are still largely separated, but we try to learn like a shared representation space and we try to bring them together. And I think with the newer class of Gemini models, and I can't probably go into too many details over here, but what we have like really moved towards is going beyond like just this grafting approach to something which is more natively unique and multimodal over here. And so that is where we see like these Gemini models like really shine or stand apart compared to say our previous multimodal works with our MedPalm models. And so I would say that with Gemini, like we've like really made the shift from large language models to large like natively multimodal models and models that can be like truly agentic in nature. And not only this, I think the other big leap or shift with Gemini models is the fact that not only were they natively multimodal, but they can do this kind of like multimodal understanding over like millions of tokens. And that allows like a lot of like interesting applications. And I know that Lena showed this graph before. And this was an interesting result at that point of time where we took Gemini voice models and we fine-tuned them on these benchmarks. So it was not like out-of-the-box performance. And so that's why these are like these Med Gemini voice models. But at that point of time, we saw that across the board, across like several different benchmarks, we were seeing these Med Gemini models like outperform other very competitive baselines over here, both specialist models as well as like other generalist models. But I think benchmarks only capture so much. And like, I think we as a community maybe do struggle to keep up with all the capabilities advances. And sometimes to really see like what these new models are capable of, we have to look beyond and we have to look at like qualitative examples. And so when we start putting these models out there, like others like creatively use it and show like capabilities. And we were quite shocked and when like some like
Hey Gemini,
folks
what
on
do you see? Can you
Twitter,
describe what
they
image
took one
I'm
of our
scrolling
models
through
from
right
AI
now?
Studio and we were able to like show demonstrations like this.
The image you're showing is a CT scan of the abdomen. It displays the liver, stomach, and surrounding structures.
What organ am I pointing to now with my cursor?
You're currently pointing to the spleen with your cursor.
Okay, Gemini, what am I pointing to now? What organ?
You're now pointing to the liver.
Okay, so I'm scrolling down here now. Gemini, what am I pointing at now? What organ is this?
You're now pointing at the pancreas.
Okay, and do you see anything abnormal on this scan?
Yes, there is a small amount of fluid around the spleen and the pancreas on the scan, which could be a sign of inflammation or injury.
Okay, anything else that you notice about the pancreas?
The pancreas appears somewhat swollen, which could suggest pancreatitis.
Okay, the patient has an elevated lipase level. What do you think about that?
Given the elevated lipase levels and the appearance of the pancreas, it is highly suggestive of pancreatitis.
Okay, what complications should I be looking for?
Based on the scan, you should be looking for complications like pancreatic necrosis, pseudocysts, and infection.
So yeah, so like when we were developing these models, we were not we were more focused on benchmarks, and so it wasn't obvious to us like the full set of capabilities. But only when we were able to like put out these models and share it more broadly, we saw like people were using it for like a bunch of different creative applications. And again, this was like very early. This was last year actually when this was when this video was recorded. It was not fully validated, but it just shows you like the kind of potential with these models and enabling like more like native multimodal interactions with the system.
Hey Gemini, what do you see? Can you describe?
Okay. There are also other, there's another completely different area of like applications with our Gemini-based models. And this is more in the realm of like biomedical and scientific discovery. And so I think earlier this year, we introduced the system known as the AI co-scientist, which is like a multi-agent system that's built on top of like Gemini, and that allows us to do systematic knowledge exploration and coming up with like hypotheses and uh, yes, I'm not going to be talking too much about that. There's another talk that I'm doing in the afternoon. If you're interested in hearing more about that, please do come over. But again, like what I want to say is with like advances in like multimodal understanding, long context reasoning, like and agentic and tool use behavior, it just opens up like a vast array of like possibilities in the space of like science and medicine, and that's what these Gemini models are enabling us. And so maybe like in general, like what's on the horizon for like medical and scientific discovery? I think Dario really put it well in one of his essays, where he said that like over the next, I don't know, 5 to 10 years, we're going to have like incredible amount of progress, where maybe we're going to make like as much progress in science and medicine as we have say over the last 100 years. And I think that's quite true because we're just seeing like this capability explosion and expansion over here that enables a lot of different cool new things. But what I've maybe shown you so far with like say with MedPalm, with like MedPalm multimodal, with these Gemini models are these are just like base foundation models. We've been not like focused on any particular task, but rather we've been trying to take like a broad array of like data sets, and we've been trying to like measure performance and trying to like improve on them. Like these are like in some ways you can call them like foundation models. But then there's like a separate axis, which is like the one that I mentioned at the beginning of the talks. Like, can we have like AI systems that can act more as like a doctor? And so that is where our project AME comes in, which is a research project that is trying to build out like capabilities in AI systems that can actually act as a doctor, as a co-doctor, and really see and like push the boundaries of that over here. And so the key question or like things that we've seen so far is like LLMs can like really excel at like question answering and multimodal interactions if all the information is like already like well curated and like presented to them. But the real challenge is like, what if the agent needs to like gather all this information on its own and have like a long-term interaction with like the patient or the human in the loop? And so that was kind of like an open question when we started embarking on this project back, I think, in 2023. And so the question was like, can like LLM-based systems, can they intelligently and compassionately acquire information from like people under uncertainty and really like help them in their clinical care journeys? And so yeah, so that led us to our project Amy. And before I share maybe more technical details on the system, maybe I'll quickly summarize like the high-level result that we had. So again, this is from like work that we first preprinted in early 2024, and I think last month it was published in Nature. And what we essentially did in this work was that we had a text chat interface, and we had validated patient actors interacting either with the AI or with like both certified primary care physicians. And so they were like us, so we were like trying to like simulate like these medical consultations over here. And so this was like a randomized study. And at the end of the study, we had like a specialist panel of physicians who would like rate these consultations, and then the patient actors themselves would like give their opinions on like the nature of the consultation. And so what we observed was that Amy was actually outperforming. Amy, the AI system, was outperforming PCPs on like multiple different axes of diagnostic dialogue. And so not only was this actually doing well on like things like, diagnostic accuracy or coming up with like, treatment recommendations, but it was also perhaps more profoundly like doing well on axes related to like relationship fostering with the patient actor, or like, like perceived openness and honesty, or empathy. And so that felt like a more profound result to us. And I think beyond the result itself over here, what maybe excited us a lot more is like the way in which we actually trained the system over here. This actually builds upon like a decade of research at like Google and DeepMind, going back to like AlphaGo and like how we pioneered like systems using self-play and reinforcement learning. And I think a lot of you will agree that like in medicine, there is actually no substitute to experience. And so my colleague, Dr. Allen, I mean, he keeps telling me that if you have like a choice between two doctors, always go to the one with like more gray hair, because they're likely to, just give you like better recommendations. But if you think about like human doctors, the number of patients they're likely to see in their entire lifetimes, that's probably going to be like, 10,000 to 50,000 patients at best, if they're like very, very prolific. And so the question for us was like, with AI, can we do better? Can we do more? And the answer turned out to be like, yes. And so what we did for Amy was that we created this learning environment. We created this diagnostic dialogue learning environment. And so we had in this environment, like Amy, the doctor agent, interacting with a patient and receiving feedback from like a critique. What it allowed us to do was it allowed us to like set up this nice self-play environment. And the thing that was happening over here was like we could simulate like a lot of different scenarios over here. So we could simulate, for example, patients with like, tens of thousands of like different conditions, like different variations of symptoms. We could also like simulate like different personalities of the patient. So we could have like patients very talkative, or like we could have like patients who are like very, very worried. We could have like patients who are like not willing to like share information. We could have like patients who are like, say, not comfortable with English. And so it allowed us to like create all these different crosses of like medical consultations over here. And essentially what was happening was like Amy, like in this environment, Amy was like essentially doing like hundreds of millions of consultations, right? And so obviously like not all of them are going to be like reflective of the real world. But we had this critique in the loop as well. And so that allowed us to like filter out and like keep the more realistic looking scenarios. And then we were able to reinforce and fine tune the model on those more realistic looking data, and as well as on like things that the model was not doing well. And I think that has been like the key factor or the key result behind why the system's been doing well and system's been improving on diagnostic dialogue over here. And so the first result I showed you was more like trying to put like the AI system head to head against doctors. But I guess the other, or maybe the more interesting question is, what happens if you were to use this AI more like as an assistive tool? Can this system really help like doctors do better on like complex diagnostic challenges or in like the provisioning of care? And so the other counterpart paper that we had to the previous one that I showed was where we took these complex diagnostic challenges from the New England Journal of Medicine. And for those of you who may not be super familiar with it, I mean, these challenges have been like going on for like over, I think, 100 years now, or maybe close to that. And they're like some of the most complex cases that like doctors are in the MGH ecosystem, I think, encounter over here. So they're like very, very detailed. They have like the full history. They have like other multimodal data. So the question was, okay, like if you were to like give, say, like a general internal medicine doctor these challenges, how well would they perform? And then would their performance improve by having access to like an AI system such as Amy over here? And so that was the study setup. And what we observed was that when doctors had like access to Amy, their performance improved on top of like what they would normally do, or when they had access to more standard tools such as like web search or like medical information books and so on and so forth. But obviously, when we put out this paper and like this graph, like people focused more on the red line, which is the AI alone. I personally wouldn't read too much into that because these cases are not like reflective of like true practice. They are like extremely challenging and hard cases, and it's probably not surprising that the AI is like doing better than doctors on this because they're not like super trained to do this. But I think the more important part is the difference between the yellow and the blue and red, green lines. And so like I tell all my friends that if you go to a doctor's office and if they are not like using, say, an LLM-based AI system like Amy in like a couple of years' time, you should just walk straight out. Because I think doctors with AI are going to be much better than doctors without AI. And since this work, which again like was also published in Nature last month, we've been doing like more, and we've been adding like more new capabilities in the system. Now we have like more of a multi-agent setup, and so we have like specialized agents that can do other things like make like come up with like treatment recommendations, like prescribe like drugs. We also now have like the capabilities to like retrieve information from like tens of thousands of like clinical guidelines and make sure that the recommendations are accurate and in line with that. We've also like made sure that the system has like this concept of memory so that like now it can do things over like multiple visits. It can remember what it has said before and then use that information to further guide the patient in their clinical care journey. And we've also evaluated this in more true multimodal settings where people might bring in like more of their multimodal artifacts, such as say I mean, they might like, for example, take a photo of their skin, or they could like have like a lab record, which they want to take like a PDF of and like send it to the model and just say, okay, these are my test results. And we've seen like how the model performs in these settings with like multimodal artifacts as well. And again, we observe similar things to the first study where the model is actually better than like even like both certified PCPs on like multimodal understanding and using that information in these conversation settings. Yeah, so all the work that we've been doing on this project has kind of like received a bunch of different attention. But I think, as all of you know, like everything in healthcare moves at the speed of trust, and it has been, I think, particularly heartening to see like the reception from like key opinion leaders in the clinical community. Again, this is an art of the possible research project for us. We've done a lot of work in like simulated settings with like patient actors, but what we are doing right now is like moving more into the real world. So we have like a prospective deployment underway at Beth Israel Deaconess Medical Center in Boston. We have like real patients interacting with the system under full supervision by doctors, and we are learning more every day based on these interactions. We're seeing where the system can be helpful, both to patients but also to doctors, and also understanding all the different failure modes of that comes with like deployments of these systems in like real world care delivery. So hopefully we'll be able to like share more towards the end of the year as to what's the impact and what we are learning. And that will in turn allow us to like make more progress and make the systems more helpful for people. So yeah, maybe what is the future? And maybe I'll very quickly provide a sneak peek into what's coming. And I think what I said at the beginning of the talk, like I think the idea of like democratizing medical expertise and making it accessible to everyone everywhere, I think that's no longer science fiction. I feel like that's coming, and we're having like these very true multimodal agents that can natively understand like information from multiple different medical sources and can integrate them and like do like very interesting stuff with them. And so an example of that would be this one where.
Hello.
Hi there. I'm AMIE, your virtual medical assistant. Could you tell me what's going on?
Yeah, so I was running earlier and I might have injured my right knee while running. And I just wanted to, yeah, talk to you about it.
I'm sorry to hear about your knee pain. Could you tell me a bit more about the injury? When did it happen? And what exactly did you feel when it happened?
Yeah, for sure. I think the pain is quite sharp. It's on the sort of outer area of my knee. I was kind of running. It was a rainy day, so the surface was quite slippery. So I managed to sort of trip over and fail. And I think that's when I must have hurt my knee. And and I thought the pain was going away soon, but then it didn't. So I just wanted to like have it checked out.
Thank you for providing me with more details. It sounds like you may have hurt your knee by twisting it while running. To give you the best advice, I need a bit more information. Could you tell me, 1, can you point to the exact location of the pain when you're using the video camera? 2, do you have any swelling or bruising around your knee?
Yeah, I would say it's around, can you see? It's around here.
Thank you for showing me that. It looks like you're pointing to the outer part of your right knee near the kneecap. While I can't physically examine you at this moment, is there...
I'll stop it here for the interest of time. But you will see that the models, and this is almost a real-time interaction. It's processing the video feed. And once like my teammate viewpoints to the location, it's able to interpret that information, integrate that into the overall conversational history, and then act on it. And so that's kind of like the future where we are going with these models. And again, it's I think like incredibly exciting, like what are capable, like full medical consultations. And so I'll end on this note. I think that is the future. Hopefully you guys have all have like a sneak peek over here, and yeah, happy to take more questions.
There we go. Well, that was a fantastic talk from Vivek, and we look forward to a futuristic world where every doctor has access to great AI resources. Questions, please. There we go.
Thanks for the great talk. So how do you decide when a specific problem is solved? So especially given the out of distribution prompts that could arrive.
I think that's maybe not for us. The real proof is like when things are like deployed in the real world. And I would say that in medical AI, at least, like we've been not very good at that. We have like a lot of papers, we like show things on benchmarks and in research publications, but the real proof is actually deploying in the real world and really helping people. And I think that's when we are on these journeys. And so if you have like a specific problem, then if that's deployed in the real world and like people are making use of it and it's helping doctors, that's when I would say something is solved. Until then, nothing is solved.
Next talk, you just show a case when you like your medicine cases study. So that's also already part of your training.
No, when we did that study, we looked at like the overlap between our training data. And I think roughly maybe 10% of the cases, there was some overlap. But there was no like explicitly trying to, train on that. So it was almost like an out of the box, like zero shot evaluation on those settings.
I have a question from my side.
Not there's an open source tool that we can use because you can try aiming person because I'm wondering how long it will take to integrate with hospital systems because I see that as a potential challenge and maybe it might not be out there in maybe 2-3 years from now, given that integration is a big challenge and all that. So just wondering if people can actually start using this on their own.
Yeah, so AMI is like an art of the possible research project. So we aren't focused so much on open source, but on like very careful development and validation. I don't expect like the full system to be ever open source, but like parts and components that go into the system can be made available. And so, for example, some of my teammates have released Gemma-based models, and probably not the same level of performance as like the full Gemini-based system, but like they're already performing quite well and people have been building on top of it. And so you can imagine building conversational systems, multimodal systems using those Gemma-based models and having like good performance, but like AMI will never be open source anytime soon.
So then I was wondering about integration efforts eventually because you mentioned with multimodality, you would get access to the like facts, information, say patient history, maybe different imaging and all of that. Do you know what kind of potential problems could be faced by Google to actually do implement this into hospitals? Because
Yeah.
I think it's a very challenging endeavor.
Yeah, 100%. And we've been trying to do this for 10 years, and so we know all the ways in which this can fail, or like the ways in which this can be difficult. Yeah, we are fully aware, but we want to take it like step by step, because while there's like a lot of potential and capabilities, there's also a lot of different ways in which this can fail and can go wrong. And we want to, do responsible development, I guess. Thank you.
Thank you, Vivek. That was fantastic. So Jay will introduce us the next speaker, and